Peptic ulcer disease, or PUD, refers to a defect or ulceration in the mucosal wall that extends into the deepest layers of the stomach or duodenum. PUD is a significant cause of morbidity and is associated with substantial healthcare costs. The location of PUD is usually in the first portion of the duodenum or the lesser curvature of the stomach. The two most common causes of PUD are Helicobacter pylori infection and the use of nonsteroidal anti-inflammatory drugs or NSAIDs. Ulcers produced by H. pylori infection and NSAIDs in the GIT results from disrupted homeostasis between factors that break down food such as gastric acid, pepsin, H. pylori, and NSAIDs, and those that promote mucosal defense and repair. Patients with peptic ulcer disease present with dyspepsia and mild epigastric pain. Patients may also complain of heartburn, belching, bloating, nausea, or vomiting. There can also be weight loss, and aside from that, complications may arise such as bleeding, perforation, or obstruction. The goals of PUD therapy are to resolve the symptoms of the patient, reduce acid secretion, promote epithelial healing, prevent ulcer-related complications, and prevent ulcer recurrence. For H. pylori-related PUD, there should also be eradication of H. pylori. Before we proceed with the drug of choice for peptic ulcer disease, let's first take a look at the normal acid production in the stomach. The stomach consists of three anatomical regions. First is the cardia, which is responsible for mucus secretion that protects against stomach acid, the body, which contains parietal cells that secrete gastric acid and intrinsic factor, and peptic or chief cells that secrete pepsinogen, and the antrum, which contains G cells that secrete gastrin that stimulates acid secretion by the parietal cells.